So we'll go to the next talk on diffusion tensor, about which we had some discussion yesterday. And the last one, what Dr. Kohli showed a picture with a lot of wonderful figures. It's not what we think is DTI. We think DTI is a protocol which has to be routinely used in brain. In fact, in almost all brain cases we do the DTI because it takes a less amount of time. Only if we are planning for a fiber tractography, we use the 3 millimeter sections high resolution imaging. All the other cases, we do a sequence which is about 3 to 4 minutes. So when you talk about diffusion, the first thing is it is a very useful technique for stroke. And we know that is the most accurate technique in picking up even lesions which are missed in CT, especially the lacunar infarctions. So it's very sensitive, there is no doubt. The timing of stroke again is possible. As you can see in this case, this is acute lesion, while a lesion here in the thalamic is an old one, so you can time the stroke. But is it very accurate? If you, we had some few cases where we actually totally missed stroke in the diffusion. This is, Harsha was asking me about the stroke protocol, and in all stroke protocols we have a flare sequence, a diffusion weighted imaging, a perfusion imaging, and a TOF MRI. So this takes about 15 minutes and on a 1.5 Tesla machine. So these, and susceptibility weighted imaging. So these are always there. And this is a case which came after 3 hours. So the patient directly went into the MR and we did. Any lesions here? This was the flare sequence. This was the susceptibility weighted. Are you picking up any findings? Actually, we saw a very important finding here. Yeah, the dense MCA. So dense MCA, which Vijay talked, is already there in the susceptibility weighted imaging. Also, you can see in the flare, this hyperintensity, that is the hyperintense flare sign. The slow flowing blood produces the hyperintense flare sign. So that is also there. The same time, we did the diffusion imaging. Any finding here? This is the diffusion. This is the ADC map. Hardly anything. But carefully, if you see, there is some changes. If you see the insular cortex, this is something retrospective. This we did not pick it up. You can see the insular cortex here and the insular cortex on opposite side. Something equivalent to your the insular ribbon sign of CT scan is seen here in the diffusion. But this was missed because what we think of diffusion is a very hyperintense lesion in diffusion which shows restricted diffusion, which was definitely not seen. So here is a case, and you can see the MRI taken at the same time, a total obstruction of the MCA. So a large MCA infarct has been missed on the diffusion weighted imaging, which has been picked up in the susceptibility weighted imaging, because you see this. Also, which I showed about this abnormal prominent veins because of the increased deoxyhemoglobin. That is also seen in the susceptibility. So a lesion which is picked up in susceptibility, picked up in flare, but is missed in a diffusion weighted imaging. So why did we miss it? We'll go into that later, and this was what happened after a few days. After about 3 days when we repeated it, you can see the same lesion very nicely seen in the flare sequence as well as in the diffusion. You can see the restricted diffusion and total occlusion of the MCA. False negative diffusion weighted is very well known, and this is mainly seen in the posterior fossa. As you can see, something at 7 hours, we see a lesion here missed in the diffusion weighted imaging, but at 48 hours you see that same lesion very well in the diffusion weighted sequence. So deep gray matter, it is very well known. Similarly, in the brainstem, it is known that you can miss these diffusion lesions. But can we improve it? Yes, we can improve it in the stroke protocol. So most of them are reversible, and that is another important thing. When you do a stroke study and you see a lesion which is diffusion, in the diffusion it is all white, does it qualify that the whole of the brain is dead? No. Now it is very well known that even areas which are bright can have difference. So what to do in such situations? You measure the ADC values. Sometimes in the core of the diffusion restriction, you can see a larger drop in the ADC in comparison to the periphery. The periphery probably is the area which you can still save. So that means what you see in diffusion weighted imaging is not always irreversible. There are areas which can be reversed. This is a case which we got. A patient had a vasospasm while doing an angiography, and almost all the lesions have disappeared after some time when the patient was treated. Now the previous case that I showed you where you missed the lesion, can you pick it up? Yes, you can pick if you increase the diffusivity. And yesterday there was a discussion on prostate, while we were discussing on prostate imaging, can you go for a high B value? The problem is, when you go for a high B value, you have to use a NEX which is 4. That means the total time for doing a high B value diffusion weighted imaging is going to increase to about 6 to 7 minutes. And can you spend that much of time in a stroke patient? So what I think Siemens or all the vendors of MR should try to do is to make the diffusion weighted imaging a technique which is more susceptible to diffusion by increasing the B value at the same time not increasing the time. So this is what you can see, a low B value, and a high B value you see the grey white matter distinction much better, and the lesions will be picked up well. The same thing when you go with the ADC also, there is a change in the signal intensity. Remember the signal drops down, the SNR becomes poor when you go to a B value of 3000 if you do use the same NEX. Now what is the importance of doing that is even slow diffusion can be picked up. If you go for a higher B value, you can pick up the fast component. The low B value will pick up only the fast components. If there is a significant restriction, only that will be picked up. The slow component you have to go for a higher B value. But still, we do it only on 1000. We are not going for a B value of 3000 or more, basically because we do not want to increase the time of scanning. B value, higher B value can also be useful when you have a tumor and edema outside, and if you want to differentiate that, a better definition between vasogenic edema and the tumor can be obtained when you go for a higher B value. Having said that, it is very rare that we go for a higher B value, again because of the time problems. Now if you go for the physiology of diffusion, there are conditions like cytotoxic edema, increased cellularity, and glutamate-induced excitotoxicity. These are the three conditions where you get restricted diffusion, while vasogenic edema is the one where you get facilitated or a diffusion which is not restricted. Some few more terms which I just wanted to discuss. Now, what do you think is this lesion? Yeah, it is a tumefactory demyelination. This is not a tumor. How do you know that? You have an open ring enhancement. And these three layers, this is a very interesting finding that we have seen in most of the tumefactory demyelination. The outer one, the outer border, is usually a restricted diffusion. You can see, because that is the growing area, edge of the demyelination. The central area here shows a T2 shine through. What is T2 shine through? If something is T2 bright and it is also bright in the diffusion weighted imaging, that area is T2 shine through, because a diffusion weighted imaging has components of both T2 and diffusion. So this area is T2 shine through, and this area is facilitated diffusion. Always in tumefactory demyelination, perfusion imaging helps because it will usually show a low perfusion. There is another image called the exponential image. I don't know how many of you use this exponential image. The exponential image can be utilized because it can tell you how much of T2 contribution is there. It will show only if there is diffusion or not. So this is a DWI image. This is an exponential image of a tumor here, which is very bright, an epidermoid. You can see that there is the restricted diffusion is hardly there. The exponential image does not show much of restriction, and it is not very black in the ADC. Actually, in all epidermoids, the restriction of diffusion may not be very marked. So that is what is shown in the exponential image. So one more image which can be easily got from if you go to the Neuro 3D diffusion task card, you can get the exponential image in all the cases.